organizers for giving me this wonderful opportunity. So after having gone a lot of basics, we are into a most common clinical problem which we encounter, assessment of LV adequacy in the fetus. Which way does the slide move? Can I have a pointer as well? Yeah. So a small left ventricle, a small left-sided structure, smaller aorta, these form a very common reason for referral for a detailed fetal echo. So whenever I get such a referral, I would do a detailed assessment. The first thing is to look for evolving left heart obstructive lesions, like a coarctation or an arch interruption. Look for progression into a hypoplastic left heart syndrome. It of course warrants a detailed assessment of the pulmonary veins. And of course, look for other associated lesions like presence of a BST or unbalanced AV canal contributing to a small left side. Normal cardiac growth in the fetus, we have gone through it many times, and we know that the right heart is the most dominant chamber in the fetus. And with progression of pregnancy, the right heart structures become more prominent. So these are 15 weeks and 21 weeks and late trimester heart images. And we can see at mid trimester, there is not much difference between the left and the right side. By third trimester, the right heart structures become more prominent. So there are a lot of nomograms to see if these structural dimensions are normal. The earliest one was proposed in the year 1992, where it was done only for a small number of 100 fetuses. And after that, there have been various other studies. Each study varied from, like from 1,000 to, each study was different. And the latest in 2018 was up to more than 7,000 fetuses. All these scores have been incorporated into standard nomograms, and they are also available online on the Parameters app, which you can download on your smartphones or see it online and plot for the Z-scores. As Dr. Shanti mentioned, it is important to use the same Z-score when you do serial assessment. What we commonly use again is the Boston Children's Hospital score, like for pediatric Z-scores as well. The most important thing is these scores are like regularly updated, so it is important to keep that in mind. The other one which I told about is the Parameters app, which is available as an app on your smartphone, and which actually plots the various fetal cardiac parameters, the ventricles, the valves, the great vessels, against gestational age or against fetal biometric measurements like the femur length and the BPD. We have gone through this already. It's important to get a good 4-chamber view to measure the ventricular size, that is the length and the width. Width is usually done in mid-cavity, and the AV valve dimensions are usually done in complete diastole. The outflow tracks gives an assessment of the measurement of the semilunar valves, the RVOT and the LVOT views. The RVOT also helps in the measurement of the main pulmonary artery and the branch pulmonary arteries. The transverse views, that is the 3-vessel view and the 3-vessel trachea view, gives an assessment of the aortic arch and the ductal arch measurements. And the same can be done in the SAG view, where we can see the isthmus measurement as well, depending on the lie of the fetus. This is how you feed in the data into the app, and it gives you the Z-scores. Why are Z-scores important? Are all small left ventricles hyperplastic left heart? That's a very common clinical question which we see. Literature says that Z-scores of more than -2 to -4, and when there is progressive worsening of the Z-scores by serial assessment, when the LV is non-apex forming and there are EFE changes, it more or less points towards a definite hypoplastic left heart syndrome. But why are we interested in this LV adequacy? Because when these borderline cases in the -2 to -4, when we have to make a decision for pregnancy. So as I told you, it is important to look at 2D measurements and look at the real-time opening and closing of the AV valves. Look at the pulse wave Doppler, both in the outflows and in the inflows. It gives you a good idea. It's also important to look at the flow across the foraminal and at the ductal and the aortic arches. Presence of an LSVC, of course, it is known to be a very common association with left heart obstructive lesions. It has been seen in pathological specimens, so it's a very common referral as well. So it is important to look for that. So why is LV adequacy important? The most common suspicion which we need to look at, I'm sorry, it's disappeared. Yeah, the most common suspicion from a small left ventricle is about an evolving coarctation of aorta. It is important to remember that when the discrepancy is more obvious in the mid-trimester, that is by 20 weeks, we have to take it with more significance. Late trimester onsets are supposed to be taken with a huge pinch of salt. Serial measurements of indices and follow-up is very important. We should also remember that there is a definite percentage of false positive in these assessments. This is a large study where big review article where they reviewed about diagnosis of fetal coarctation. And they have come out with certain measurements like the LV to the RV mid-cavity ratio. If it is less than 0.6, it has a sensitivity of about 70% and specificity of 67% in detecting fetal coarctation. When you look at the iota-PA ratio, PA to iota ratio of more than 1.6 has a sensitivity of 83% and specificity of 85% and a positive predictive value of 62.5%. So it is important to look at these measurements and very important to follow them serially as well. Of course, the measurement of the ductal and the aortic arches in the transverse views, the assessment of the isthmus in the sag view, and the ratio of the isthmus to ductal diameter. These indices are also important. Versus in LSVC, again, it has been seen in pathological specimens that LSVC is more common in those hearts with congenital heart disease. So the odds ratio of cardiac defects being coarctation fetuses with the LSVC is about 61%. This is again only from pathological studies. Doppler is an important tool to look at the retrograde flow in the arches, which again suggests a definitive duct dependent circulation in the neonate. And when we look at various parameters, a combination of these four factors, that is the isthmus diameter z-scores, the isthmus to duct diameter ratio, presence of a definitive coarctation shelf, and the isthmus flow disturbance in the form of retrograde flow. And when we use all of these factors, there is an 86% detection of true fetal coarctation, which requires immediate newborn surgery. I'll go through some of our patients who were all referred as a small left-sided. In fact, all of these patients have been doomed like a evolving hypoplastic left heart syndrome. I'll go through the next few patients, how they turned out eventually clinically. This was a 25-year-old primary gravida with no risk factors in pregnancy, and she was referred at 20 weeks for small left heart structures. This is a fetal echo. You can see the prominent ductal arch, and you can see a definite small left-sided chambers. Right heart is prominent. The mitral valve is opening well, definitely in long axis as well. As I open the outflows, I'm able to see ascending aorta, which is smaller, definitely, but there is antegrade flow. There's a prominent pulmonary artery and a ductal arch. The pulmonary veins are normal in this view. The LVOT is normal, and it's very difficult to image the aortic arch. And Doppler did show a retrograde flow. So when I put in the parameters for the z-scores, it's all very obvious that they're all like -4, -4, -3 for the mitral valve and the left ventricle. So with these factors, when there is left ventricle is not apex forming, there is echogenic endocardium, and there is retrograde flow in the aortic arch, and your z-scores are really low, I would counsel this as a definitive hypoplastic left heart syndrome. The next patient is a 40-year-old primary gravida. She was referred at 22 weeks for chamber asymmetry and smaller left heart structures. Pardon me for that mistake. So this was a fetal echo. At 22 weeks, we can definitely see a smaller left side, a bigger right side. Inflows are normal. The outflows also, the aorta coming out is normal. The foramen ovale is flowing very well. This is a reassessment at 28 weeks. Again, the flows are normal. You can see the LVOT to aorta. There is antegrade flow in the aorta. And when I try to image the arch, I can see the arch, which is very hypoplastic. And when I put color Doppler, I'm able to see retrograde flow from the ductal arch. So this patient was counseled very much to be an evolving coarctation. This baby was delivered in arch center. And of course, these are z-scores. As you can see, they progress from -2.7 to -3.4. And I used other z-scores for the arches as well. So this patient with progressive worsening z-scores, definitive antegrade flows, and retrograde flows in the arch was counseled for an evolving coarctation. At 6 hours of life, the echo show hypoplastic transverse arch with a narrow isthmus, a large duct with no gradient. On day 3 reassessment, it was a restrictive duct with discrete coarctation, and this child had an arch repair on day 3 of life. The next patient, 28-year-old primary gravida, referred at 26 weeks for chamber asymmetry with a smaller LV. So she did have a small LV, but normal outflows, normal flows in the arch. This was a 28-week fetal echo, 26-week fetal echo. And at 32 weeks, again, at reassessment, we can see some kind of smallness in that arch with some aliasing. So we could still not rule out that it is a normal, definitely small left-sided structures. When I got to the Z-scores, again, borderline, -2 to -3. So this family was counseled very cautiously that we have to look for a postnatal echo. So on postnatal assessment on day 1 and day 3, there was no gradient. There was a very small PDA, and this child did not require any newborn intervention. This child is at follow-up now at 1 year, 10 months, and you can still see that small narrowing there near the isthmus, which is still present in this child. So far, no significant gradient. This is a 35-year-old priming Gavada, was referred at 18 weeks for small left-sided chambers, definitely doomed as an evolving hyperplastic left heart syndrome. She did have very difficult fetal position to examine. But what was very striking was the presence of a VSD, which was very obvious below the outflows. And there was some definite overriding of the aorta as well. The ductal arch was prominent, and the aortic arch was comparatively narrow. So she was again reassessed at 20 weeks, and we could see the Z-scores were floating between -2.4 to -3. So this patient, we did not see after 20 weeks, but then she came at term for delivery. And of course, to remember other things in this same fetus, there was a definite deviated cardiac axis, which points towards an outflow tract abnormality. There was definite VSD with an aortic override, and of course, a narrow transverse arch compared to the ductal arch. So this patient was delivered at Arch Center. On day 1, there was significant coarctation with a large depth, and it was a DORV VSD. So this child had a surgery on day 2 of live coarctation repair and PA band, and at 6 months had a complete DORV repair with PAD banding. This child is 15 months old now and is on normal at follow-up. This was another 24 weeks priming who was referred as smaller left-sided structures. See? Last patient. If you look at the fetal echo, here again, there is a definite VSD there. The left heart structures are small. There is an aortic override. The aorta is smaller compared to the PA, and the ductal arch is more prominent. So this child, antenatally, my suspicion was it was a double-outed right ventricle with a smaller dimension aortic arch compared to the ductal arch and a smaller mitral valve. Postnatally, this child has a DORV VSD with very mild ischemic hyperplasia and no gradient. So there was no requirement for newborn intervention in this child, and this child is waiting for a DORV repair right now. So if you see, small left-sided structures are markers for several evolving lesions. Mid-trimestral onset of asymmetry is more significant. Serial assessment and follow-up in pregnancy is very important, and presence of other factors like presence of a VSD and the Doppler across the valves, the PF4, the arches is very important. And counseling is to be done with caution about the possible postnatal possibilities. There is one message I'd like to all to take home, like all small left heart structures are not hyperplastic left heart syndrome. Thank you very much for a patient hearing.